You never can tell. All right. Don't be shocked. I'll figure out which one of these is the best of the three I'm doing today. Send it all the same one. Nevertheless, uh, two things. You want to join a party? Getting started. It's okay. Before that fashionably late. Making an entrance. I'm joking. It's how my wife and I met. So, moving on. Two things. One, I sent you the quote unquote formal notification where I have to change the syllabus, which I've never had to do, by the way. But because of I said the way I phrased it, the unique circumstances we're stuck with, that you're stuck with, and now thankfully that hopefully will be ending by the end of next week with a doubled up lab. That's why we're going to effectively. It's just too complex. Drop the lowest exam. A lot of professors do it. I just don't. And the reason I don't is because when you're in a mostly you're in a healthcare related discipline, that it's dropping it suggests, well, I can get a do. It's hard to get do-overs when it involves people. Just that's my philosophy of it. Okay, you learn by your mistakes. I mean, I realize. Here this is an unusual circumstance, and so I'm doing it for your benefit. And surprisingly enough, you out of nowhere comes another benefit. Okay, you'll be happy to hear that. Maybe somebody mentioned it to you already. I sent you this message. See, if you did not know, and you probably did, that basically there's every discipline, not every, but for instance, if you're in nursing here, they have to be certified by an organization, so it's a certified nursing school. In order to, and you wouldn't get a job if it wasn't. If you're going into nursing, for instance, or whatever discipline you might be in, depending if you're in a health-related discipline. Just like the school, we have what's called middle states. Middle state certification, it really is every 4 years awarded. Every 2 years, kind of do a self-study, and it basically lets you know if there's anything amiss. Long story short, basically that when you're in one of these we're in a core science course, both this and the lab. So whatever Dr. Robbins is doing on, and he doesn't necessarily have to do anything with it. We want our students to all take this. They permit me in writing when I got this from my boss that we are allowed to offer an incentive. I am going to offer you a grade-related incentive. You don't have to thank me. Money would be. I'm sorry, I was recording. Thank goodness somebody's. So, it's on the next exam only, and I plan on October 29th for this next exam. I have to come in costume. I have no idea. It's a Steeler game over whatever costume. So, for instance, if you got a C plus on the next exam with the scale, that exam, if you complete this, I don't know who completes it because they send me a list, we'll bump it up a grade notch. It would be fun. For instance, if you end up with C, you'll go to C. You get the idea. So all those in favor, make sure you complete that. The assessment is not gradable. It's basically kind of get an idea of sort of the general knowledge of the students here on, how shall I say it, on just general science stuff. I didn't even look at it, so I don't know what's on. There's no penalty. There's no right or wrong. I'm just looking for participation. Yes?
Should we, since we're taking this in the lab, do we include that we're in both? Or do we
I have no idea. It goes to my name. I mean, I don't know what's going on in the lab. I don't ask.
It's just like asking you what class that you're doing.
Right, and this would be mine. Yeah. Whenever if they ask for a section, your section number is D. I call my dog Doofus. Let's get this. That was flashing away there. Okay, so that covered. Now we get on with work. So that's all taken care of. All right, so everybody out there, and we're ready to go. I'm still recording. And this is a fracture nugget, so I better call up that PowerPoint, which I didn't do for some reason. Not very smart. But you saw what I was drawing on the board. And so if you're listening or not here or listening to this virtually, I just have to sort of follow the sound of my voice, and we'll look at it. And this is all about the fractures. I'm very fond of doing this particular presentation. I have a lot of experience in it. Okay, the other stuff is to me somewhat boring, and I understand it. When you're doing basic physiology of something like this. So again, a fracture is an interruption in the overall integrity of the bone. I don't care if they call it a chip, a crack, it's an incomplete fracture. It doesn't count. Oh, we don't even think it's a fracture. It's a break in the, whether it's microscopic or macroscopic, whether it shows up in X-ray or not, it is a fracture. Period. End of sentence. The bone is broken. That means it's going to heal in a particular way. It's going to follow certain steps, which we look at briefly toward the end of the presentation on how you classify fractures. I am not going to show you one of the pictures and say, oh, by the way, this is what, it's this kind of a fracture or that kind of fracture. You're not going to have to do this. So. But I'll ask you some generic, like you're going to see. If one of the questions, shh, don't tell anybody. Oh, so everybody looked up, thankfully. Is that I didn't even tell the other classes because I like your class better. Because at least you smile occasionally at bad jokes. And it will be that if a bone is broken into 3 or more pieces, you're going to see comminuted fracture. So the question is going to be kind of a la that. Okay, description, you classify it based on it. But I'll give you the whole spiel about it. And I agree. Most fractures result from trauma when you're young, and as you're older, we call it a pathological fracture. That implies a disease process. The most common by far and away is osteoporosis, which we're going to do that at the very end. We're going to do that on Monday. That's Monday's nugget before we start joints, which will be also on Monday. And there's other things that are pathological fractures. Cancers in the bone, diseases of the bone, nutritional problems associated with bone, hereditary diseases of bone. All of those kinds of things potentially. So if it's not from trauma, some other disease entity, they're referred to as a pathological fracture. You see a lot of those. I have a ton of experience in that because they're more often in the elderly. This is what I was writing on the board. So, wait, I'm going to classify the items. As you know, because when I framed it, when you're looking at a chart, but these days, whether it's all computerized, you look at the computer screen, you go to their studies and you see an X-ray that says, they have you're taking care of them now, and they had a displaced fracture that was reduced by a blah, 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 blah. The distal tibia or whatever was some kind of joke. You know what they're talking about. See, the descriptions that you read on an X-ray report, a CT, an MRI, effectively should allow you to paint a picture in your mind of what it is. Without actually having to see it. That's why it's just basically go to my radiologist. You should be able, and it's not just you, but anybody, because the report should be consistent. So if I say to you it's a non-displaced fracture, I've got a bone, without even talking about the direction of the line, I got a bone, basically fractional. Now, that's non-displaced. The pieces haven't moved. They're still aligned. Now, if they're separated, or they're shifted over a little bit, but still basically aligned, call that displaced. And then you have to characterize what displaces. There's a 1 centimeter gap between the two fragments, blah, 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 that type of stuff. On the other hand, you may have to say that one of the fragments, typically say proximal or distal, superior or inferior fragment, was angulated. Oh, it's angulated 15 or 20 degrees medial. You don't have to, you're not going to be the ones doing it, but you should be able to understand what it looked like when they saw it initially, what it looks like. Then the distinction, complete and incomplete. Complete means it goes all the way across. So the entire bone is fractured. So we call that through and through. Kind of think of it like a cylinder, and like you're sawing a cylinder on one side, you're through it, but it's all the way through the other side. Now you're fractured. Or it can be incomplete. And down the road, we'll explain the difference, I will, between an incomplete fracture where the fracture line doesn't go all the way across and what's called a green stick fracture, which is exclusively in children. They're not equivalent terms. And that's important also to understand. And this is, why do I make such a big deal about classification? And you will learn to make a big deal, because when you classify something, we are able to diseases, conditions, a patient's condition from a nursing perspective. Are they a fall risk? Are they not? If they're a fall risk, now you got a whole set of things you need to do. Okay? And then bang, 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 everything comes from that. If they're not a fall risk, you don't. That's why we classify it. From a doctor perspective, if someone's got a grade 4A cancer, that tells us how extensive it is, gives us an idea of the prognosis, and it tells us what medications we have to use or not, or if it's worthwhile treating. All of those things are all part of it. That's why we have this kind of information. Well, and this is true, and whether it's an infection is the same way. There's a whole set of ways that this is done. Someone has HIV, we have to look at different things. We talk about this in micro, something called their set point, and basically determines what medicines are appropriate, how often, blah, 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 blah. If you're not doing it, you're deviating, and this is the most important 3 words I can tell you, probably the whole term. It's called standard of care. Standard of care is what you are expected to do for someone. Okay, and it has to go with community guidelines or national guidelines or etc. But if you deviate from standard of care, you better have a darn good reason. Question? No. It's a fair point. So with standard of care, it's just that. Look, if I say, oh, well, this is such, why didn't you use this medication? Well, they're allergic to that medication. Okay, good. Well, we couldn't use this because they're allergic to that. We couldn't use this because there was an infection that was ongoing, or anything. You have to have a good reason to deviate from standard of care and document it appropriately. That's to understand, because you have to understand what's expected of you, and there's a reason why you're not doing it exactly in that way. It's just something you have to understand, that you're always followed around. If you're in a profession involving taking care of people, there's always, in any profession, medical legal implications. Some lawyer who's going to want to make money, and you don't want to have your name on the chart. I hate to put it that way. I mean, I'm not saying that people aren't harmed and don't deserve to be compensated. Thank God, I've never sued anybody, okay, but I've been sued. It's no fun, ladies and gentlemen. It is no fun. And I am more than willing to spar with a lawyer. I mean, they're no smarter than I am. I mean, you understand that lawyers in malpractice cases, they become experts for a brief period of time on the thing, and they forget about it and go to the next case. I'm willing to go after them. But it's mentally and physically exhausting. Moving on. And so all of that's the precursor. These are the fractures. The last, and the one I missed, I'm the stupidest guy in town. That! The single most important criteria is open or closed. All that other stuff is just describing it. Open means not this nonsense. Skin is penetrated. Means the bone has been exposed to the air. Penetrated was having you suggest that there's a piece of bone sticking out. Not always the case. Sometimes the bone will stick out, you trip, you fall, you hear something crack, and you look down and go, oh my God, and you immediately twist while you're doing it, the bone goes back in. You have to probe that wound sterilely if you see the skin open and see if it goes down to bone. In that case, the bone was out. It doesn't have to be out now to see it. You could take a chunk of skin, fall. I did that without thankfully exposing the bone over the summer. Nailed the step, okay, took a big chunk of skin. Fortunately, it didn't go all the way down to bone. Okay, that would have exposed it to the air. How many times have you stubbed your toe? Maybe somebody's seen it, your nail started to come off. You learned about the nail bed in the laboratory. That's right on the bone. There's no other underlying tissue. If the nail bed's torn, guess what? The bone's exposed to the air. What that means, the bone is now infected. Presumption is always that the bone is infected and it must be treated as such. The requirement is the antibiotics. The requirement is also, and I put this into your ears and remember it, tetanus prophylaxis. That is classified as a tetanus-prone wound. So you're obligated, to make sure of that individual's tetanus status. Oh, I had a tetanus shot last week. Okay, fine. Look it up, confirm that they did. Good to go. Documents. All that's super important. So there's a lot of this stuff. It goes past all this crappy stuff I gotta learn sitting here in A&P to understand how it's going to affect many of you career-wise. And that's what I think the relevance is. And I mean, you're young, but you don't have the world. The problems in the world get closer to you the way you get older. And then as you reach a certain age, they get farther away. Okay. Like, it's like I say, I'm going to be 75 next birthday. What are you going to do? Fire me? The only person who wants me to continue working is my wife. I don't want you in this house. Then I have to listen to you all day. That was thank you. God bless. One person, two people. The rest of you on your phones. Don't have children. Moving on. So that's really important. And why is that important? Because it limits your options of how you can treat any of these fractures. If the bone has been exposed to the air, it's not like you can go down and operate immediately. The most you can do operation-wise is put things kind of in place, but you have to leave the wound open because it's just too much of a risk. If you try to do anything aggressive to it, it's likely to get infected. And I'm not guessing that this has changed in the 25 years or so since I've been treating fractures. Because this treatment's been around for a very, very long time. So be familiar with that. So here they are. This is what I was telling you before. This is called comminuted. Typically, if there's a through and through fracture line, you've got two fragments. 1 and 2. But if I put another line in there, now I have 3. So you have 2 or more fracture lines, lying 3 or more fragments. That, by definition, is comminuted. It could be 50 fragments. There's no limit once you get above the 3. So you could have, if this unfortunate incident would have been exposed to the air, the skin was torn off, the bone protruding, or at least open to the air. That is called a comminuted compound fracture, or a comminuted open fracture. The terms are not mutually exclusive. So you always want to describe anything in clinical sciences, in medical sciences, nursing sciences, healthcare sciences, as completely as possible to avoid confusion. That's part of the deal. So here we are looking at it. Yes, is it commonly aged? Yeah, these are not old bones. This, if you look next door, that's osteoporosis. That's typical of an older bone. This, well, my guess, just from the location being, a little bit above, maybe 6 inches off the ground, probably a car bumper. So maybe, an accident, oil versus pedestrian loses. And that's what happened here. Assuming it was closed, you could probably wire or pin or screw those things together. You can see it involved both the tibia and the fibula. Hard to tell from that. So that's comminuted. This is a pathological fracture we call a compression fracture, by far and away the most common. Yes, sir.
So we got to know how each break is, like how the compression went from a fall.
No. You would have to know if it's pathological.
Okay.
So this guy, and believe me, this would be the example. We talk about osteoporosis, typical, true or false. A common fracture associated with vertebrae in elderly people is referred to as a blank fracture, okay, or a pathological fracture, true or false. That would be that kind of question. See, interacting, I like this. Even if it's just asking what's going to be on the test, at least I feel we're reaching out. Okay.
So the compression fracture, the pathological.
That is a pathological fracture, yes. It's associated with a disease of the bone, in this case osteoporosis, the most common. And this is, and what yields from this is how a nerve would get pinched. Because it closes down, you don't have to know this. That intervertebral foramina, you might have learned about it in lab. Basically, that round opening gets kind of squared off, pinches the nerve, and sciatic pain, kind of this thing kind of happened to me with a disc. And I suspect the underlying, and probably arthritic changes were the underlying reason. And basically, I have, for the last 12 years, I've got no real sensation here. It doesn't hurt. I can do whatever I want with it. It's just funny when you can't feel this. It's all about where the nervous patient. So not all of these have tragic consequences that are there, but some can be really problematic. And if you wonder why it's particularly people with osteoporosis, particularly women, get smaller with age. My first wife was not. She was at best 5 feet and 1/2 inch tall, under 5'1". Probably now, and that was when we were married. That's almost 50 years ago, 47. Now she could be 75 her next birthday. She's probably lost a good 2 inches. And I'm going to cite her again, and she knows that I refer to this with students because of osteoporosis. She was the classic example of early onset osteoporosis, and so she did everything possible to try to limit the effects. It's just sometimes the deck was stacked against her. We'll get to that with osteoporosis. As I told the other group, she's happy now. She just got new living room furniture. She's ecstatic. You get all the pictures with the grandkids and all that, those text things with like 10 people on them. And you always have to put like the heart or the thumbs up, show you're interested. You know what I mean? Right? You've done those? Oh, how cute the baby is. I'm running out of things to say. And he's very cute. I have pictures. You're going to get stuck with the Halloween pictures. Just get over it. You're going to. Just deal with it. Remind me Monday. I'll show you the picture. My sister was 80 yesterday. Picture of the two of us. Thank God she doesn't look a thing like me. Can you imagine her being 5'8.5" and 200 pounds? She's like 5'1", then weighs 97 pounds. Same that she weighed in college. Just spit. It's not fair. Okay. I'll do this one in a minute. This is a classic epiphyseal plate fracture. So this is in a child. You can see the growth plates that are there. So, I mean, and what you can see from this, and they do a pretty good job with the illustration, here is the distal aspect, the femoral condyles, and you can see the femur has basically, the shaft is sort of fractured along the epiphyseal plate and shifted. So it is displaced. You don't have to know that or anything. I'm just showing you for context. That's there. How do I know it's a kid other than the illustration? I can see the growth plate here. Okay, and I can see where it is here. And then you can see because of the smoothness rather than having something like the spiral fracture is particularly evident of a growth plate fracture. You don't have to know any of those. There's a whole classification system, beg your pardon, for that that I share with my advanced students, and they don't have to know this system yet. Because we do all that. If a fracture ends up in the joint from this, it has really significant implications. So if that fracture had gone through the condyles into the joint area here, then you're dealing with the possibility of an irregular growth at the joint, and the whole bone might be cockeyed. This is the kind of thing where once it's put back into place and held there by whatever means necessary, it should be fine. They despite as ugly looking as it is, this is not as bad. It generally has a predictably good outcome. Just to give you an idea, and that's classifying. Then we can tell the parents and go, look, this is good. We're going to be okay, barring anything unforeseen. Versus, oh, it's through the joint. I'm going to have to send you to a pediatric orthopedic specialist because this could affect the way the bone grows in the future. You got to be upfront with people. Tell them what's going on. This is a spiral fracture, and yes, it is a common sports injury. Okay, that is not a child because you can see the osteoporotic bone you would not see in a child. That's an older person. Okay, this would be a child. You can see the density that's there. And you can see what happens when it spirals. Rule number one: Remember, the tibia and fibula, I'm sure you had this in lab, connected. Okay, there's a membrane there called the interosseous membrane, right? Just like the radius and ulna. The one in the radius and ulna moves, tibia and fibula is pretty sturdy. So if you had a spiral, enough force to create a spiral there, look on the fibula and go up. There's often a fracture up there. We have a whole, again, classification system that was developed mostly in Scandinavian countries, particularly in Sweden, because they have a lot of downhill and cross-country skiers. Imagine this kind of an injury. The ski boot doesn't separate, gets stuck, and the person continues to fall and it twists. And there's a whole way that we can figure out not only what the treatment is, but where the likely injuries are and their extent. It's got a fancy name. You don't have to know. It's called Lagi Hansen. This is the kind of stuff that orthopedic surgeons or people in my field who get board certified in orthopedics, like I was, have to know to take your boards. And it's the type of thing you always look up afterwards, but I didn't have to memorize all this junk. It's there. Okay, so that's in the adult. We do see them in children. Okay, typically they're more upper extremity than lower extremity. They could be in lower extremity. Okay, they're traumatic in nature. What would be the underlying reason potentially? What would be a guess? One class did all right. The other one, I had to force the issue. I'm not saying, I mean, there's no penalty for guessing. The most common reason would be what? For an injury, for break a bone. Anybody's bone. Trauma. Be courageous. If you saw a child, I'm making a very important point you can see. So a child is the first thing you better think about. If you see a spiral fracture in a child is what? The hint is the welfare of the child can't speak for themselves. Thank you. Excellent. So you got that one. Good for you. Because I know you were the one time you guessed it wasn't. We learn more from that. Every faculty member in here knows that. Do not be afraid. Going to the nursing, you're going to be doing a lot of talking. They're not going to let you sit there and go like that. It's going to be like, okay, you've got your seating assignment. Okay, boom. What's the answer to this? What's the answer to that? Okay, got it? Be prepared. Abuse, neglect, whatever. This is the teaching point. This is the life lesson. Science life lesson. Do not have to look, depending on your position, if you notice something like that, you are working there, you have to report this to a superior. You are the supervisor, you probably have to report this to whoever is the attending physician. If you're a nurse practitioner, this happens when you're the only person here, you have to take a certain step. This must be reported to social services. If it's a child with a spiral fracture, you're not making a value judgment. Licenses, you'll hear me say this multiple times, are very hard to get and very easy to lose. And you might think the family is loving and caring. You might know them. They might be relatives. They might be friends. You don't have an option. You're legally, if there's a possible concern of neglect or abuse, it needs to be reported. Let the authorities figure it out. It can happen to anybody. I'm completely transparent about this. My daughter, I adore the very ground she walks on. She got pregnant when she was 15. When she was 14, she was awful. Not so much to me, terrible to my wife. Okay, at the time, my ex. And one time she just started lambasting her with every name in the book, and I just, one morning, and she was going to middle school, like 8th grade. I had my ring on, not this different ring. And she had a little thing here. The school reported it. They knew what a pain in the neck. I was going to use another word, but I won't. She was, but they are obligated to report it. Was I mad at them? No. They came to it. This is absolutely true. They came to investigate. And so she had to be there with my wife, my ex-wife and I at the time. And they're talking, and she gave the lady who came from social services from CYS a worse time. And she said, okay, you might head back to your room or go to another room, close the door, and you talk to mom and dad. She looked at us and goes, I can't believe that you didn't kill her. She goes, I was strangled. She literally said, I would just, how did you restrain yourself? I said, took some work. We were completely, she put, you're fine. You must be great parents to put up with this. I don't know if we're such great parents. It's an absolutely true story. Let them do their job. Their job is to assess the household. Why is this so important? Because if that same family in the emergency room, hypothetically, had gone to it 3 weeks later, went to another hospital with yet another injury, possibly worse, possibly, oh my God, worse. And they found out, and they will, that they were at your hospital and your name's on the chart and you didn't report it, which was obviously something that required reporting, your license could go. Hospitals don't like it because they see that's giant lawsuit coming their way, and you're low man on the totem pole, so to speak. Got the idea? I'm being very honest with you. I didn't make up that story about my daughter. I did not. I told the class the same thing. I can't tell you how many times she's called me and go, Dad, I have no idea how you put up with me, how awful I was to you. It kind of goes with the territory. Yes, ma'am.
The old fracture, did it happen like just because of the growth plate? Like, can it happen to adults or is it just kids?
It'd be just kids because of the presence of the growth plate.
Okay.
That's all. Has to be there. It implies only in children. An adult could get a fracture at the same area, but it would not be an epiphyseal plate fracture. Because that's a zone between the shaft and the head, or the shaft and the base, and that often is an element of weakness there, structurally. So I hope you're getting some idea. I don't mean to be preachy. I'm trying to save you a headache down the road. It's the same thing if you're working in one of these places and you're, how should I say it? It's that same lady who comes in, oh, what happened, dear? Oh, I fell down a flight of stairs. And and I both know that, you go back and look and there's a broken arm and a twisted ankle. There's an abuse situation going on. And somebody needs to do something soon. That lady's going to end up in big trouble. God, you always you feel responsible that actions are justified based on what you're seeing. But fortunately, early on in your career, you're going to have somebody you're going to report it to and let them make the decision. But try to get an idea what's going on. This is the depressed skull fracture. There's nothing really remarkable about that. Okay? This is what it doesn't look this bad. But effectively, this is that sandwich of bone. You have cortical bone, the outside of the inside, and the marrow. What happens? Something strikes people in the head. And the indentation will kind of, the whole force creates the interior cortices, or the cortical bone there, to crack. The big problem with this is there going to be bleeding. Particularly, you could have something called a hematoma, either subdural, and we'll look at this. We do nervous system, or subarachnoid. We'll get to where those locations are. But that puts a tremendous amount of pressure on the brain. And what you'll end up learning about this, if you don't know already, it hurts like anything, these headaches. You only can take Tylenol. A stronger medicine has respiratory depression, number one. You have to do neuro checks if it's a kid, and you have to wake them up or wake the adult up every 15, 20 minutes, half an hour. How you doing? And you look for any signs of, the pupils not behaving properly. They're being really out of it. Other than the fact that you just woke them up out of sleeping. Okay, and the one that they don't teach you that I know about, because this is what you hear about when you work in emergency rooms, projectile vomiting, particularly in children. Let's say they were at a game or a soccer game. Oh, little Johnny hit his head and blah, blah, blah. Look out for projectile vomiting. That happens. It really suggests pressure, and probably there's a bleed, and they need to go, not to the urgent care, not a knock on urgent care, but you're not going to have anybody there who's going to be able to drill a hole into the skull and get fluid out of it. It's just not. You have to understand, some things are fine for urgent care. If you're in micro with me, I'll tell you the story about an urgent care that diagnosed my wife's Lyme disease back during the COVID lockdown. Perfect, fine. Nurse practitioner did great. But some things are, some things require a different level of treatment. And basically, how do I treat them? This way, reduction means to reduce the deformity. Closed means you don't have to open it up. Maybe it's, it could be, the finger could be way up here or down here or the wrist. And you basically anesthetize them, either local with sedation or general, put it back into place, put a cast on. Sometimes we do it, you'll see it. Sometimes you have to insert pins through the skin and incorporate them in the cast or some device on the exterior. But closed means you're not intentionally opening up the area to examine the sites, remove bone fragments, put metallic hardware inside. That's an open reduction. Okay, and so open reduction, and when we talk about stuff on the inside, it's called internal fixation. And it's important for you just to recall these terms because these are terms that every hospital uses. You're on orthopedic floor, oh, this patient is status post ORIF, open reduction with internal fixation hip, or whatever. It's coming your way. If you're rehabbing it, if you're in physical therapy, you know what they had. All of this. So I'm trying to share it. I'm not trying to show off that I know about all this stuff. If I didn't know about stuff, why would I be entitled to teach you? And so I am mobilizing it, and it all depends, how long. No, that's not the part of this course. How do they heal? This is the healing part. So, and I'll show you the pictures. When anything breaks, okay, when anything is damaged in the body, it doesn't have to be a bone, healing starts right away. Process of inflammation starts because cells are disrupted. We studied all the cell, all the lysosomes and all that crap inside. They're disrupted. They start to spill their contents. That irritates the area, that provokes inflammation. When it's inflamed, okay, there's a whole cascade of chemicals. If there's bleeding, some of those chemicals will induce the blood to start to clot. Okay, it will produce white blood cells will come and gobble up stuff. That's what inflammation is. In a fractured bone, whether it's tiny or whether it's large, this is what happens. Bone has a ton of blood vessels. There's a lot of bleeding. And it starts to form a big mass or clot. It's very rare that it would be so extensive that the person could bleed out. A bad hip fracture, that could happen. There's so much blood supply in the hip that there's one kind of a hip fracture and everybody's aware of which one it is. You remember we learned about the trochanters? It's called an intertrochanteric fracture. There's so much bleeding from that, you have to. But that's an emergency amount of work on right away. You got to go in there and stop the bleeding and make sure the ends get close together. Because the next morning they may not be around necessarily to do it. I hate to not trivializing it. So it forms this thing called a hematoma. It's stretching that periosteum. It's inflamed from all the white blood cells. It's inflamed from all the chemicals. And you can see when it's stretching this area of the periosteum, that's really hurting it. But understand, in its first 3 days, it's starting to send chemical signals. The fibroblasts are going to make fibers. The chondroblasts are going to start to make cartilage. And even the osteoblasts are going to start the early process of repairing it. In those 3 days, white blood cells come and gobble it up. So phagocytic cells clear. That's why sometimes you see a fracture better a few days later. You mean, no, we'll take an x-ray the next week. Oh, I knew it was a fracture. I just didn't see it. Now you can see the extent. And then we begin to see collagen fibers, fibroblasts, cartilage cells, osteogenic cells. They create a mix. And what it does is it forms initially a fibrocartilaginous, they call it callus. Callus just means hard. So it's a hard surround of the fracture site. That takes roughly about 3 weeks all told, average. Some sooner, some later, depending on the extent. And so what happens is, this is what it looks like. And what we could start to see as it begins to form blood, the cartilage is going to respond to it, and it's going to start to change into bone. And so over that next, depending on where the fracture is, 2 weeks, 4 weeks, 6 weeks, whatever, it's going to start to form bone, and it develops a bony callus. The bony callus, the bone starts to form early, okay? But eventually that so-called hard callus and the bone, spongy bone, will be cortical bone down the road. Typical time when we see it pretty well formed, and it should be 2 months. The 2-month X-ray after a broken bone, assuming that there's any kind of significant fracture, very important. And then lastly, over the next months, maybe up to a year, it remodels to the point where you would basically, here's the bony callus. And so the remodeling basically changes. Cortical bone gets put in. It looks like if there was nothing there, stressors on it. And eventually, like if you had a broken bone, unremarkable, any of you, in a year, you wouldn't even know it was there. The bone would completely remodel. If they had to put metallic hardware and that kind of stuff, you don't. Then, because you would see evidence of it, whether it was left in or even if it was removed. But eventually, that would disappear as well. Yeah, the older the people are, a lot of times forensically, they'll see evidence of old fractures, and that gives clues like to identity or sometimes causes of death, things like that. And so that just summarizes all of that stuff, and we're doing this later. So this other stuff is just for me to show you. I found this website. All I did was Google, fracture images. It's over here. There's a UK. It says radiologymasterclass.co. They don't do comms. UK. And it's got all this stuff, and you start looking at the different fractures, how you describe them. So transverse, cross, oblique at an angle. That's a fifth metatarsal. Pretty common bone to be broken. There's a large tendon that inserts here at the base. You can actually lop off this piece of bone. When you lop off a piece of bone like that from the pull of a tendon, it's called an avulsion fracture. AVULSION. So you hear the term, oh, that was a avulse. We pulled off, yanked off. And so that probably is what created the force. That's very common in sport. Very, very common. Here's a spiral fracture, dull bone. You get a good look at this. Look at the severity here. You can see that it's very distinctive. And they call this a sagittal plane. It's along the long axis, but look where it goes, right into the joint of the tibia on the lateral aspect. So that's right in the lateral condyle. We're going to do joints here. You're going to hear the most complicated joint in the human body, the knee. This person's going to end up with knee problems and knee arthritis. Interesting. Here, this is a calcaneal fracture, inevitably from a fall. When you fall, and I had one that was much more severe in a patient of mine. He was a truck driver. He was used to jumping the 4 feet off of the base of his thing all the time. He was all over the country, over the road driving. And what happened was when you fall, anybody falls from the height, you land, you always check the heels. They fall forward, you got to check the wrists. Because the force is generated up through your back. You got to check the tripod. His foot, everything was, I can't even tell you how many fragments, 10. I mean, there were lines everywhere. I looked at it, it's swung like this. I put in what's called a compression cast, a bunch of cotton and like a cast like a shell on it, just to hold it in place, crutches. And I called up the lead orthopedic foot specialist in Pittsburgh, from where my office was quite a few miles away, about 80 miles away. And I said, please, let me refer you to this guy. Because I know it's way above my pay grade. I mean, I'm sure that he just had to try to put the pieces in place, hold it. I'm sure this would all have become arthritic. I'm sure they would have done a fusion. The fusion in this joint is something they do for things like that. And I'm sure it shortened his career. So the severity, you see some things, and the note is for that, and you're all going to experience it. There's something, maybe you're a nurse and you're starting an IV. If you're having trouble with it, here's a great word that we use in the hospital all the time. Help. Don't try to do something when you're not comfortable doing it. You give it a try. If you're having problems, somebody else in to help you. Please. No shame in it. Patients appreciate that. Way above, they don't say, oh, you don't know what you're doing. No. People are a little bit reluctant There's nothing wrong with it. This is probably, I would say this is somebody who was beat up. Because to get all these fragments in upper humerus, got to be a mess. Here's that, remember that, like that typical, I drew on the board. There's that section, that chunk. That is a metacarpal. That, I mean, could be anything. It's probably here, this neck of the woods. I mean, a sharp object came down. I don't know, just guess. But that should heal pretty well. Here's, oh, this is a mess. Tibia and fibula. I mean, who knows what did this? So I think they're interesting just to look at for fun. I don't get a lot about rotation and displacement. You can look at that. And I mean, when you get these types of things, this is a combination. Displaced, kind of overlaps. They're showing angulation. So I mean, this is a real problem when you get things like that. Watch out for fractures above the knee and above the elbow. Blood supply can be compromised. And I mean, this is a pathological fracture. Look at this. This one is that multiple myeloma is a cancer of a certain kind of white blood cell in the bone marrow. Most of the time, you have to sterilize the bone marrow and do bone marrow replacement. It doesn't always work. It's a bad diagnosis you do not want to have. You can see what that's like. Imagine the bone marrow is just shot. Here's a tumor. Again, the fact that it's tumor doesn't mean cancer. 90% of tumors are benign. But it doesn't mean that they can't, if they're growing someplace where they shouldn't, they're weakening the bone gives way. That's a pathological fracture. So you get some ideas. I do want to show you with some of the, this is the stem. This is probably the stem of, let's say it's the femur. It's the stem of a head and neck prosthesis for a hip replacement, let's say. And then just to give you an idea of some of the metal that goes into these things, it's wild. I'll show you that. It's coming up. Well, this, oh, there you are. So this is the kind of thing. If you have this, we'd have to plates and pins and screws to hold everything in, and then putting it back in order, which is what you have to do with all that thing. That's called a POTT, capital P-O-T-T-W, Trias fracture. Thank you, and have a great weekend. We'll do the rest of this very little, and we'll start joints on Monday.